Hello and welcome to Silver Lining. My name is Peter Abraham. I'm a registered nurse, predominantly in the field of hospice. This channel talks about resilience in the face of storms, but also nursing topics, specifically hospice. I do want to give a shout out to Dr. Andy A. I apologize, I don't want to try to pronounce your last name, but Dr. Andy A. is a hospice and palliative care physician who on LinkedIn reached out to me this morning to state that he was reading the book Mastering Hospice Eligibility and wants to recommend it to his team. And this is written from a hospice nurse myself to other hospice nurses, taking into account all the experience I've learned over the years. Interviewing is unbelievably important, but it also goes over different scales. I mentioned this in a previous episode. Covers your major LCDs, but stuff that's not covered in the LCDs. Sepsis, for example, goes over a bunch of scales and indexes and how to use them. So thank you, Dr. Andy, for that wonderful compliment. This week I did finish the publication of the Art of Hospice Visit Planning. In the hospital setting, it's very easy to keep an eye on your patients. So outside of using nursing prioritization, you don't have to worry about how you're going to plan your day. A hospice visiting nurse, we have a lot of juggling to do. Some of the juggling is how do I map out my day and my week, and I do cover that in the book Mindful Minutes, Time Management Secrets for Hospice Nurses. That goes over dealing with both rural patients, city patients, how to map out your day. But when it comes to planning visit frequencies, that's a combination of art in the sense that it's subjective, but how can we apply objective elements to it? Nursing is science and an art. Nursing is science and an art. So the art part's going to be your clinical gut, your judgment, which if you're a new hospice nurse, you will develop that over time. It's something that will come to you over time. Give yourself grace. Be patient with yourself. The science part is looking at those objective elements. Sometimes the science part is extremely easy. You're with the patient and the caregiver told you that the patient was vomiting overnight, and you should be interviewing. Don't just take, oh, they vomited or they had emesis. Was it coffee ground emesis? Interview, ask questions, color, etc. Oh, it's coffee ground emesis. I have to monitor my frequencies. If this was a patient I was seeing once a week or twice a week, I better be coming back tomorrow. As I say this is me. I'm going to do me, you're going to do you. I'm not your boss. I'm just sharing that if it's patient-centered care, this is where I would encourage you to look at your schedule for tomorrow and say, how do I fit that person in? They're going to need your support. So in the Art of Hospice Visit Planning, I go over part of the art, and then how can we make it more objective in a way that has science behind it. And in that book, I start off with, in chapter 1, looking at some of the traditional methods that have been used. Chapter 2, looking at what we're seeing in the visits that should be triggering what do we do with the visit frequency. Chapter 3, just pause here, I'm just paging through the online version of the book itself. I don't have the author copy yet to show you. I did order a copy that should be coming in between January 9th and the 15th. But in chapter 3, thanks to Nurse Stacy, that showed me, I believe it was last year, the Sunset Scale. So the Sunset Scale is a science-based method. Now it doesn't take part nursing judgment. Science-based method where it's looking at what's their activity level, what's their nutrition level. We're doing contrasting. This is what they were the previous visit, whether that was scheduled or PRN, versus now. What's going on with their body temperature, and what's their work of breathing. And by looking at that, they're basically, it's like another scale. It's like the palliative performance scale. This is just another scale. You're coming up with a score. Best score is 4, worst score is a 0. So the lower the score, the more intense. The lower the score, you need to increase your visit frequency. So after you do the scoring system, your activity 0 to 4, your nutrition 0 to 4, body temperature 0 to 4, work of breathing 0 to 4, you're going to have a scale. It goes from anywhere from 0, they're dead, to 16, which they're stable. Now, stable is a bad word in hospice. Me to you, we could use the word stable. In our documentation, we are not going to use the word stable. We have to meet eligibility requirements. I mentioned that I was thankful for Dr. Andy appreciating the Mastering Eligibility book. There are certain words we avoid using in hospice in our documentation. But from nurse to nurse, colleague to colleague, we can use those words. So score of 12 to 16, we're not going to adjust our frequencies, fine. And you could even ask yourself the question, depending on what else is going on in your day or week, could I bump them down to a degree? Scores of 18 to 12, you have enough change going on, your team should know about it. 8 to 12, there's enough changes going on, notify your team. Now, I'm not sure how to word things. I'm better in writing than words, and this is an unedited video. If you're like the majority of us, you're going to be having a stand up and a stand down, or some type of team communication during the day where you summarize. So bedside nursing, you go in for your shift, you get the bedside report, pros and cons, and when you are done with your shift, you're giving report to the oncoming nurse. Hospice, we're out there in the field, we're driving, and we're walking to our patients, so we don't have that same type of mechanism, but we should be doing handoffs to the triage, making sure they're prepared for anybody who might turn into a hot mess, which you want to head those crises off at the pass. Scores under 8, look at increasing the visit frequency. So chapter 3 goes over the Sunset Scale. Thank you again, Stacy. Chapter 4, how do we integrate and compare methods? You have the traditional method versus the Sunset Scale that adds a little bit of science to it. And chapter 5, my favorite chapter, how do you prevent crises when you're able to prevent them? It's going to sound odd. How can you, I'm not a prophet, you're not a prophet. How in the world can we develop a method to decrease crisis? And this is critical for many, many, many reasons. We want to make sure our patient-centered care. You want the family to love you to pieces. Not saying you're irreplaceable, but you want the family to appreciate your care. You want your teammates to appreciate you, that so-and-so is not getting called out for triage to drive out in 1, 2 a.m. in the morning if it's preventable. And you want to get those good scores, when the family or the medical power of attorney fills out the survey within a period of time after your patient passes away. If you're really keeping track of I go over this in the book Whispers of Time. If you're really keeping track of the changes of condition that's happening, I talked to Nurse Tanya a couple of days ago. Tanya, if you're watching this video, hi. Nurse Tanya reached out to collaborate, just brainstorm a glioblastoma patient. What could we be doing in terms of keeping this patient comfortable? And so we collaborated, got some ideas going on that. And Tanya, you're amazing nurse. Thank you so much. And I learned from that conversation, and hopefully you gained some insight as well. But if you're paying attention to that, and getting back to where I mentioned the caregiver said the patient vomited, and you dug in deeper and it was coffee ground emesis, you're planning a PRN visit. You don't necessarily have to change the routine visits. There are pros to keeping up with your team and saying, I'm going to be doing a PRN visit. There's pros from not adjusting the schedule rapidly. Depending on the software you're using, you can set up a schedule matrix. There are pros to throwing in PRN visits. In terms of having your clinical leaders seeing a bigger picture that you may not be able to present in words or other methods. Actions speak louder than words. By your doing this may be not only to the patient's benefit, but to your benefit, and showing the Medicare, everybody's on their toes. So in the 5th chapter of The Art of Visit Planning, it goes over how to be proactive with putting in those PRN visits. And it goes over that. So that book, both the Kindle version and the paperback version, are available on Amazon.com. In the link in the description, it has the entire book list. I'll be sure to include the links to that book, as well as the other books in the Empowering Nursing series. But that's there. If you have any questions about this or other videos, please feel free to comment. When Tanya reached out to me, she did it via Messenger. Could I give her a call? I gave her a call. And it wasn't a sales call. Hey, Tanya. Hi. I can talk, and here's my rate. I can't say it'll never come to that for any of the collaboration I do, but this was free. I was on the phone with Tanya. I didn't time it. I know it was more than a half hour. Might have been 1 or 2. I didn't time it. But it was free. We both learned from this. We both benefit, and her patient benefit. And I was grateful when, Tanya, when you reached out. I'm thankful to hear that there was closure for that case. And I'm sorry for your loss, but I'm glad that we collaborated. We were able to work out a battle plan. So if you're a nurse and you have questions, I am not going to judge you for your questions. Not just Tanya, I have other nurses, whether it's by messenger or texting. Peter, this may sound horrible, but this is what I'm running into. Well, number one, 9 out of 10 times, maybe even close to 100% of the time, it does not sound horrible. You're probably on the right track. You just need somebody else to bounce your idea upon and look at something in a different light. Look at something in a different light. And I'm willing to be that person to the degree that I'm able. I can't promise turnaround time. Tanya got me at a good moment. I normally don't check Facebook Messenger that often, but I was looking, new message. But I'll do my best to respond timely, to answer questions, whether it could be hospice, it could be nursing in general, it could be how to write and publish books on Amazon. I don't claim to be an expert. This is just entertainment purposes, educational purposes. We're not establishing any type of certain type of relationship. I'm just out there trying to help my colleagues and for all of us to be uplifted and be there for our patients. So we're coming close to the new year. Happy New Year, everyone. Um, I'll be probably looking at next week what is the next book I'm going to be working on. I did apply to my first position in Kentucky. We'll see how that goes. And it's just one step at a time. Where I'll leave you at in terms of looking at the resilience part of this channel. I'm part of the Hospice and End of Life nursing group on Facebook. And one of the patients out there, I love that group. I love everybody in that group. There's patients in that group. There's social workers, chaplains, fellow hospice nurses, CNAs. It's a whole kit and caboodle of people supporting and encouraging one another in that group. So there was a patient who posted, she has been on hospice before for such and such a disorder. She came off, but now she has another diagnosis, and they told her that she could qualify for hospice. And she was asking questions that's very, very common. These are normal questions. Is there hope for me? Is there hope for me? And the answer is yes. And that's not the fairy. It's not a cliche. Hospice is about living. And all of us who work in hospice, no matter how good we get, and I consider myself at expert level in certain areas of hospice and palliative care, we're not God. I've had patients come on hospice that got better. I may have shared the story of the 104-year-old who may have a chance to be 105 next year, which is around the corner. People can get better on hospice. It is not a death sentence. But I told her, in terms of looking at resilience, make the most out of every day. Have a bucket list. Prioritize the bucket list. I like using the Eisenhower matrix. It's not an ends-all, means-all, but it's a way of putting it in perspective as to how much energy it takes and how much am I going to achieve from it. But even if you work on the smallest item in your bucket list, got one thing done, you made progress. And you're not going down the drain. So anytime that you're facing a storm, acknowledge the storm, acknowledge your feelings, don't circle the drain, but work on those items. I got something done. I'm going to talk about saving yourself by doing stuff in terms of going to heaven or hell. Heaven is through faith in Christ Jesus. But we are talking about being resilient in the face of storms. You accomplish one thing that brings you joy, or at least neutral, you've won for the day. That's it for this video. Thank you for watching. God bless. Like, subscribe. Happy New Year, and bye.